Welcome to the Cincinnati Children's Hospital Heritage Video Series. These videos are a project of the Medical Staff Historical Committee. I'm Dr. Meyer, a retired community pediatrician. With me today is Bea Katz, who is a longtime former employee of marketing and communications at Children's. So our topic today is the ongoing history of cardiology at Cincinnati Children's. We have two long-term staff members here with us. We have Dr. Dick Myers, emeritus professor of pediatrics, former director of echocardiology, and we have Dr. Tim Knilans, also professor of pediatrics and director of electrophysiology. So welcome, thank you for coming. We like to start off with just having each of you tell us a little bit about how you ended up here, how you ended up in cardiology, why Children's, why'd you stay? Dick, you have seniority, so you get to go first.
Age does make a difference, I guess. I don't know. In any event, when I was doing my residency, obviously I had a rotation through cardiology, and with Dr. Kaplan and Molly and so on and so forth, I was very entranced or interested, let's say, in doing cardiology, but didn't think much more of it. I finished my residency and then went into the military for 2 years at Quantico, Virginia, with the Marines to help take care of their offspring. Mm-hmm. And all of a sudden we got this letter from Dr. Kaplan, which my wife opened. Mm-hmm. And when I came back from the clinic, she says, well, I know where we're going when we leave here. He'd offered me a position as a fellow to come back. Okay. So that's how I happened to come back, and was very pleased that we did. And that's how I sort of got started in cardiology. Started my fellowship and then continued on from there.
Good, good. And we'll come back to the specifics, but Tim, why don't you?
Well, I had kind of a roundabout way of getting here. I actually came to Cincinnati for medical school, and I knew I wanted to be a doctor, but I really wasn't sure what I wanted to do in medicine. Mm-hmm. When I was in medical school, since this was such a strong pediatric program, many of the people who taught me in medical school were pediatricians. I remember specifically like Lenny Kleinman teaching physiology, and I was like, I like these people, I want to be like them. And so I decided I would do pediatric residency, and I stayed here for pediatric residency. And no offense, but when I was about halfway through pediatric residency, I realized when I finish this, I'm going to be a pediatrician, and I don't want to be a pediatrician. So I couldn't really decide what to do, and I looked at different specialties and all the electives that I did. I thought, well, this is really cool, I want to do this, and then the next month, this is really cool, I want to do this, and I really couldn't decide on anything, and I was really kind of in a quandary. And then I was in my third year of residency, and Rick Martinez, who was the senior cardiology fellow at the time, came to me and said, Dr. Kaplan wants to see you in his office. And that usually wasn't a good thing from personal experience. And so I went to Dr. Kaplan's office, and he said, how are you doing? I said, fine. Waiting for him to tell me what I did wrong. And he said, we were just wondering what you were going to do next year. And I said, well, I don't know. I said, I really liked my cardiology rotation, but I liked neonatology, and I like gastroenterology. And he said, well, we've discussed it, and we think you should be a cardiologist. And at that point I thought, well, it seems like fate has kind of intervened here and told me what I'm supposed to be doing.
It is Dr. Kaplan after all.
So so he said, I'll make you an offer. He said, do 1 year of cardiology. All these other things you've told me about, they would love to have somebody who's done a year of cardiology. So if after a year you decide you want to do something else, you can go somewhere else and do whatever you want, no hard feelings, and that was the deal. So no offense to Dick, but when I started cardiology, I thought it was the biggest mistake I had ever made in my life, because cardiology at that time was Dick's field, echocardiography. Mm-hmm. Echo was everything. And to me, echo was like, well, this is cool. I mean, you don't have to do a catheterization anymore. You can take a picture and make a diagnosis, but it was kind of mundane to me. It was like, okay, it's a VSD, and then the surgeon did surgery, and we went, and there's another VSD, and here's an ASD, and it wasn't that exciting. And that's when I stumbled across electrophysiology, and that has been my passion ever since.
Now this was when in the
This was, I started fellowship in 1986.
Yeah, okay, okay. Now you came on staff for
79.
79.
Oh, on staff, I came
Well-
probably 71.
71, yeah, okay.
Yeah.
And as a fellow?
81 rather, because I got back.
81.
Yeah, I think it was.
I know you were here in the
Right.
mid-70s, yeah.
67, 69.
Yeah,
I
okay.
became a fellow in 69.
Yeah, okay,
So
there
in
we go.
71, right.
Yeah,
Right,
that makes-
right,
yeah,
okay.
So tell us about what was the cardiology, I mean, this is interesting, Tim saying, it wasn't much of a lot. What was the department like when you first came on? How
Well, the
big was it?
department
What were you
was
doing?
relatively small.
Yeah.
I mean, we had 3 staff, 4 staff individuals, including Dr. Kaplan.
Yeah.
And there were only 2 fellows at that time. One of the fellows was Jim Henry, who was a junior fellow at that time. And so it was relatively small. And as somebody had mentioned before, we were down in the basement of the hospital.
That's right, yeah.
Across from the labs, where they did all the work. And anyhow, so, but we were fine. There were, 4 or 5 secretarial helping people. And then I, of course, happened to be interested in this new technique of ultrasound that I'd heard about. And Dr. Kaplan and the chief of radiology were very good friends. And so he let me use their machine to kind of putter around with, if you will.
Was that Dr. Silverman then? Or
Silverman,
it was
yeah, Fred
okay,
Silverman,
okay,
right?
okay, yeah.
And so I would borrow the machine every now and then and try to adapt it or modify it to use it on children and use it in cardiology. At that time, and that's where the person that I'd written the book with, it was his equipment, so he and a couple of other people helped me modify the equipment so I could use it as an echocardiograph rather than just a plain ultrasonic equipment. So we'd be sharing it between radiology and cardiology. Whenever I could get my hands on it, I would try to bring it down and work on it. Right. And at that time, I had, the adults were using ultrasound, cardiac ultrasound in the early 60s up in Indianapolis. A fellow by the name of Feigenbaum was using it, so I went and spent some time up there, and they let me take their unit, and I went to some of the pediatric wards and started practicing.
Around town?
No, up in Indianapolis.
Up in there,
yeah,
okay.
Yeah. So that when I got back here, then I said, well, why don't we try to buy a machine or get a machine and have it modified? So I worked with a number of companies to help modify the transducers, the things that you put on the skin and record, and also modify the equipment over time, like Hewlett-Packard and some of the other people that I'd worked with. And so that's how I got my start. And at that time, the only people using pediatric echocardiography, even though as boring as it sounds, was actually in Sweden and South Africa.
So no one else?
Nobody else in the States had. And I thought, this seemed kind of weird because it seemed like an obvious, why not use a non-invasive, to me, kind of an approach. And so we used to work, and I worked with another staff person, Dr. Schwartz, and we would try to determine whether or not we could rule out congenital heart problems or whether he'd have to catheterize them. And so that's
That
what
was the
led really
alternative.
to my first publication in '72 as to how we were able to show that you could actually make a good diagnosis without having to take the patient to the cardiac cath lab, which added, additional risks. So in any event, that's how it all got started. And
So can you talk about how it impacted the field of pediatric cardiology?
It took a while because nobody else in the country was doing it. So, as we started to publish and as people started to come, and I had a couple of courses that I would hold, so people from Boston, people from Arizona, people from other, we'd have a course and show them how they could apply it. And it sort of started to catch on, and more people started using it. And I think probably maybe the late 70s, I don't know, when it really started to catch on, and people said, you know what, this is really a good thing to do. And obviously it was, and that's probably the first or second thing that people get besides the EKG, which is always first, but right beside it is the echo machine, because the EKG may not show anything, it may be perfectly normal, and so they'd get the echo and then determine whether or not there was some congenital malformation. So I don't know if that answers your question or not.
Yeah. And you do this now prenatally as well,
yes,
right?
Fetals.
When did that?
Echoes. We started doing fetuses, I don't know, probably in the late 90s or early 2000s, I think. Is when we started applying it to the pregnant fetus or pregnant moms and the fetuses to see if there was anything major going on. And sometimes that was a blessing and sometimes it wasn't, because if we found something, and particularly if it was significant, then of course the parents were all upset. But on the other hand, then we were prepared if we had to do an operation, because at the same time they were modifying a lot of the surgical instruments, more miniaturized, so that they could operate on the fetus or the babies, even, and now they're even operating in utero, but that's really very still early. In any event, so that's sort of led into the fetal echocardiography.
But since you just brought up about surgery, and again, I know neither of you are surgeons, but kind of in general, how's the management of congenital heart disease changed over the period of your careers? What changes? I mean, again, I'm not asking about real specific technique, but prognosis, timing, that kind of
it's really
stuff.
progressed more to neonatal surgery, fetal or neonatal surgery, and even when I was initially a fellow, many of the surgeries were delayed until children were larger and better surgical operative risk, lower risk, to now doing surgery much sooner with much better outcomes. Both the outcomes at the time of surgery, but also the long-term outcomes are much better when you don't let things languish 4 or 5 years before you do an intervention. You basically do an intervention right away.
What's is there a typical age? Is it usually before a year?
It depends on the operation, on the underlying problem. But for example, going to things that even when I started my fellowship, we weren't even intervening on, like hypoplastic left heart syndrome. We weren't intervening on those patients because other forms of single ventricular heart disease that would survive longer than 7 to 10 days of life. Intervention on those patients was done very late, so the sort of what we call the Fontan operation was done when kids were 7 to 10 years old. And now by doing earlier interventions, we can make the outcome. Those Fontan operations are much simpler, they're much lower risk, they're done at a much younger age, so a Fontan operation now would be done like between 3 and 5 years of age, as opposed to 8 to 10, or even sometimes teenagers we did Fontans on, with not good results. That was kind of a very bad time for us because of, again, letting things languish for long periods of time, because we knew that if we did things sooner, it would have a bad outcome, and so you waited, and then you still had kind of not a very good outcome. It was better than otherwise, but certainly the advent of neonatal surgery, I think, really was a major turning point.
So now more and more children are surviving,
Absolutely.
and that's really led to a whole different set of issues, right? And we wanted to talk a little about adult cardiology and your involvement in establishing a program and where it is now.
It became clear to me that our kids were growing up. And there were older people, and when I was over seeing patients at the University Hospital back in the 80s and so on, I said to myself, you know what, we need to establish kind of an adult clinic over here at the University Hospital, which I did in 1990. And then, you know, as it got larger and larger, it was decided that maybe we should bring it over to children's, because that's where all the other people like Dr. Knilans and other people that may need, you know, have some input. It was much easier to operate out of children's. It was sort of like convalescent hospital, for those of you who even remember convalescent hospital, and back in the old days. When we moved, my wife worked at children's, or at convalescent, but anyhow, so it made it easier then to work out of children's, and so we established a clinic there in, I think, maybe 2000, 1990, 2000, something like that, and had the clinic established at children's, which made it just easier to see them there.
And what are some of the issues that the survivors into adulthood, what kinds of issues do they face?
Well, a number of them required repeat operations. When you operated, for example, if they had hypoplastic left hearts, or they had transposition of their great vessels, and they had small pulmonary arteries, and you enlarged those, they may have had to have them revised, and so on and so forth. So a number of these patients would have had 2, 3, even 4 operations. And in fact, I've even followed one of my patients who required a transplant because his heart started to, you know, undergo congestive heart failure and so on. So those are some of the issues as they get older, and then they develop electrical problems, which then
more than half will have some form of arrhythmia problem, either slow heart rates, fast heart rates, either need pacemakers or implanted defibrillators or catheter ablation procedures. So it's a very common problem with repeated surgeries, and again, surgeries.
As a result of the surgery or the underlying condition? Or
Some of each.
Some of each.
So some of them it's the underlying problem, and some of them are from the surgery.
You have to understand, anytime you operate on something, there's always scar tissue that's left.
Right.
And the scar tissue can then interrupt the normal pathways or whatever goes on. And that's, I think, what Dr. Knilans is trying to say, that, you know, it's a little bit of both, that, you know.
And then risks for pregnant women?
Well,
You mean
That
women who
women-
had congenital
Women with
heart
congenital heart
Yeah,
disease.
become pregnant.
well, they have to be followed a little bit more carefully, and I had worked with, for a number of years, with an obstetrician, gynecologist over at Christ Hospital, and we would follow them. In fact, my former echocardiographer technologist would work with him during the day and would identify things, and I'd go over maybe 2 or 3 times a week and help, you know, explain to them what's going on and what to expect. And if the women had problems either with excess fluid or whatever, then, you know, the obstetrician would be able to handle that. And, you know, I could work with the family to kind of prepare them for what might happen, because many of these children, for example, one of the lesions or defects that Dr. Knilans just mentioned, the hypoplastic left heart, we'd operate on those children in the first day. Okay, whereas in the old days, he had to wait until they were big enough to be able to withstand, you know, anesthesia and surgery, et cetera. And again, with the onset of micro apparatuses, you know, and equipment, it made it easier to operate on the infants, the small infants, instead of using big, you know, tweezers or whatever, you know, they could use micro,
tiny tweezers.
and that made it a lot easier. And the same is true with the echo now. You know, they made micro catheters that could be used, that we, that one of our people, Dr. Kimmel, got very involved in. and also with the transgenic mice that they're able to use to try to look at what could be the causes, how to figure out their mutations and genes, et cetera, et cetera. But anyhow, it's sort of getting off the subject. But yeah, that I think it helped the parents. First of all, they were aware ahead of time, which is sometimes good or bad because then they worry, obviously. On the other hand, I was able to help them understand that there was a fix for the problem, and not to be as concerned as if we suddenly, when you delivered, you said, "Oh, by the way, you've got," and then all of a sudden, it's right in their face. So anyhow, that's how we kind of handle that.
And I think you were talking about like mothers who have congenital heart disease themselves.
Yes.
Right.
Which is kind of the next stage, and we're really finding that many more women who have even more complex heart disease are able to carry successful term pregnancies. So they do require close observation and sometimes interventions during the pregnancy, but it's really pretty remarkable that even with relatively significant heart disease, they are able to get to term with their pregnancies. So.
So let's go back to your area of interest, the not so
Sure.
boring thing.
The exciting part of cardiology?
This is the exciting part.
It is.
This all sounds pretty exciting. So how did you get into this?
So again, at the very early part of my fellowship, I knew that echo was not for me, and electrophysiology was very interesting, and really all of the other people who were fellows at that time got into cardiology because they wanted to go into cardiology. Dr. Kaplan didn't talk to them and say, you should be a cardiologist. And so they all said, I want to do echo because echo is really cool to me. Whereas it wasn't to me because that's not how I got there. So when I stumbled across electrophysiology as being really fascinating because it was like nobody seemed to know much about it. It was very complicated. And so even as first year of fellowship, most of the other fellows would say, oh, that patient's got an arrhythmia, call Tim, he likes this stuff. And so I was very involved with arrhythmia patients from very early in my fellowship. And then Dr. Winston Gom, who was the director of electrophysiology at the time, gave me the best recommendation I ever had, and he said, if you go somewhere like you go to Boston Children's, which is the biggest pediatric electrophysiology program in the country, to do additional training, you'll do maybe 10 or 15 EP studies during your year. He said if you go to an adult program, you'll do 10 or 15 studies in the first week. And so I took that advice, and he referred me to a friend of his who is still a giant in adult electrophysiology, Eric Brostowski, and I went to train with Eric. I planned to go for a year. I stayed for a year and a half, learned about electrophysiology. And really the principles of electrophysiology are the same in adults as they are in children. There's some minor differences, and I think it's just, as Dick was saying, that you could do echocardiography on adults, adult patients, and children were different in many ways, but they were similar in many ways. So you could learn things from the adult cardiologists. And I was sort of fortunate in timing because I came into electrophysiology right at the beginning of catheter ablation, right at the beginning of implanted defibrillators, and so all those things were all just brand new. Eric actually had not done catheter ablation. It had been started, first case in the world was done a couple of years before that, and it was actually done by a fellow that he had trained in Oklahoma, and so I had been there for about 6 months, and he said, I think we need to start doing this catheter ablation, and so we need to go to Oklahoma, and we need to learn from Sonny Jackman how to do this, and so I went with Eric to Oklahoma for several days for their first cases, and then I started doing them with him in Indianapolis, and then when I came back to Cincinnati Children's on faculty, I actually spent 6 months down at Texas Children's doing pediatric electrophysiology, but when I went there, they weren't doing catheter ablation, and that was really the biggest program at that time for electrophysiology, and I think we did one of the first catheter ablation procedures on a child in the world here in Cincinnati back in 1990.
And what was that for? What
So
I mean, arrhythmias,
It was
but a particular...
for supraventricular tachycardia, so it was sort of the very simple cases for catheter ablation. So we started out with things where you could basically find one tiny spot in the heart, if you could kill, 1 millimeter by 1 millimeter area, that cured a patient from having, severe and frequent problems.
And just zapping it.
Exactly, and no, that's exactly right. We basically, it's electric cautery, so it's the same thing that they use in the operating room with electric cautery, where they stop bleeding and cauterize things. And the initial unit that we had was basically an electric cautery unit from the operating room, and instead of connecting it to the thing you touched inside the body with the probe by the surgeon, we connected it to a catheter, and we just turned the energy on. And
you knew where to go based on the EKG?
We knew where to go based on the recordings from the catheter, and then at that time we were using x-rays to see where the catheters should go. And that's progressed to today, where probably 70% of our cases we don't use x-rays. We do everything with magnetic navigation. The system then, again, was basically just a standard catheter that had wires through it and metal contact on the end, and we delivered energy. And the problem is that if you heat the tip of the catheter up too hot, if it gets up to above 100 Celsius, then it actually boils blood. And so that's not good.
Not a good thing, no.
But it's also not good because once you boil blood, then you can't deliver energy anymore. And so then you have to take the catheter out and clean it off. So now the systems are all integrated systems where they actually measure the temperature at the tip of the catheter so that it adjusts the amount of power that it delivers, so that it doesn't deliver too much power, and it's a servo mechanism to maintain the proper amount of power delivery. And then even catheters now that actually deliver energy, but we deliver saline, so during the time we're forming the lesion, the saline actually cools the tip of the catheter so it doesn't get too hot, and we can deliver more energy into the tissue and deliver a better lesion. So again, all of this technology is all within the last 25 years.
You foresaw this is where this field was going.
I had no idea where the field was going. I knew that to me, like I say, the field to me was fascinating because it was very complicated. Nobody seemed to know a whole lot about it. We didn't have Google. We didn't have. You couldn't just go online and look up articles. You had to go over to the library and dig out books and articles and things in the library to learn about it. And like I said, that to me was the fascinating part. And now, again, to see it come along as it has over the years, it's been very amazing.
For this kind of arrhythmia, is the catheter ablation, is that pretty much standard of care as opposed to medication?
So we use medications in younger children, because especially in newborns, the risk of the procedure is a bit higher. And the other thing is that in newborns, that type of arrhythmia can spontaneously resolve over time. It's got about a 50% chance it'll go away by itself. In older children, it has really become the standard of care. There still are obviously risks to the procedure, so we don't force it on people. It's an option. It's an option that many people will take, but medication still is an option as well.
And generally, the success rate?
The success rate acutely is about 99% for that type of arrhythmia, and the recurrence rate after a successful procedure is somewhere around 1 to 2%. So our long-term cure rate's about 97%.
Wow, fantastic.
Yeah. So this is a little out of order, but listening to both of you talk, I mean, both of you were involved in innovation and things that really have changed the field. Have you benefited by the institution supporting you in this work? Is this an environment that encouraged you to be innovative and to take some risks, right? To take some new approaches, or it just happened?
It just happened.
I think the institution wasn't the one that supported us, but rather our leaders, as in Dr. Kaplan, supporting. And he then, of course, would be dealing with the people that live up on this floor.
Okay. Of course.
And of course, they didn't live up on this floor all that long. But anyhow, and tell them that this was really important, and that we the institutions should support it. And I think that's how we got our support and encouragement to continue what we were doing. Would you agree?
No, I really agree.
we didn't necessarily go and, beg
the case.
for,
Yeah.
but I think our Dr. Kaplan or subsequently Dr. Schwartz and subsequently whoever the chief was at the time would be the one to,
Yeah, but these things obviously require significant cost. There's a significant cost in
Investment, yeah.
acquiring the equipment and maintaining things and having the personnel, and so it's a significant investment there. And I think that as Dr. Meyer said, there really has been strong support from the hospital for those things.
I mean, I'm guessing you have your own specialized technicians, not just an EKG tech, but managing all these different devices.
Right.
Yeah.
Yeah.
Yeah. Both of you obviously have been leaders in your particular field. Within cardiology, has Children's had other firsts or led the way in other areas of cardiology that you can think of, or have we got the
Probably,
two biggies?
Speaking of the technology, I was instrumental in helping to develop the American Registry of Diagnostic Medical Sonographers, so that they had to be tested and had to go through training and so on and so forth. So I assume the same is true with some of your electrophysiology techs as well. And they have to be qualified so that when they come into your lab, they know what they're doing and they're not running around. You say, what do I do next? Type of thing. They're there to help. And so that again was back in the 70s or 80s that we got that all organized out of DC and so on. But so that's how that kind of developed, I think, in terms of the technologists or the assistants, as it were.
So obviously, in the history of Cincinnati Children's, one of the things that we are very proud of is the heart-lung machine and the development of the ability to do open heart surgery on children. I think Elaine's question was similar, like what other kinds of, are there other things that are really noteworthy about what's happened here in
certainly
Cincinnati?
Interventional cardiology, starting with David Schwartz, with pulmonary balloon valvuloplasty, and then carried on currently by Russell Hirsch, Brian Goldstein, with placement of stent-mounted valves, both pulmonary and aortic valves, device closure of ductus arteriosus, device closure of ASDs, VSDs, and then sort of hybrid operations. So, unfortunately, Dr. Morales isn't here today, but Dr. Morales interacting with the interventional cath doctors to get them access. So sometimes they can put a device in, but it's hard to get there from a percutaneous access, so he'll open the chest, and instead of having to actually open the heart or even stop the heart to close a VSD, he can do a ventricular approach to close a VSD. So again, I think really the pendulum is shifting on that from open interventions to more catheter-based interventions for the plumbing of the heart as well. I actually have an undergraduate student who's working with me this summer, and the first day that I met her, she said, "I want to be a cardiothoracic surgeon." And I said, I said, I have to warn you, by the time you finish your training, there may not be any cardiothoracic surgeons.
Well, that's interesting. I mean,
Wouldn't that be something?
I was going to say, and that's
Yeah.
probably not too far out there. Yeah, that's pretty amazing. That's pretty amazing. So now you have a heart institute.
Yes.
How did that all come about? It just got more and more complicated.
Well, I think it started when a fellow by the name of Jeff Robbins, who was doing lab work in, on cardiac muscle and cardiac intervention at the university, and then we somehow or other he came over here to work together with us, and that's about the time that the institute was formed. Where
I think Jeff actually had been here for many years prior to that in molecular cardiac biology.
He launched the division,
Right.
molecular cardiovascular biology.
Right.
Yeah.
And so then, was it Jeff?
I think it really probably was Arnie Strauss was the
Strauss
one who
started
really spearheaded the whole thing of
That
having
concept.
having institutes to try to bring, try to not have silos for everything, but
Yeah.
bring people together.
Yeah.
And that's, the Heart Institute was formed in, what was it, 2008
Nine.
or something,
Something like that.
2009.
Okay, yeah, okay.
With Jeff Robbins as one of the first co-directors, and then Jeff Tobin as the other
Yeah.
co-director.
Yeah, can you explain a little bit to our viewers about the structure, what makes that Heart Institute structure unique?
So it's basically to bring together cardiology, cardiothoracic surgery, and
Basic research.
the MCB, the bench researchers. It's really done a great job of that, I think, in terms of getting us to think of things out of our area. I think it's been helpful in terms of organizing things for things as mundane as purchasing and equipment and things like that are used across the board, that you can have more power by purchasing more things. So I think that's been helpful as well. But I think the biggest thing is just being able to get minds together, to have conferences together, so that people aren't working in their little area and they've got somebody else working 150 yards away, and the two people are working on things that are very similar and they don't even know it.
Right.
I'm working on a clinical problem and they're working on a problem in the lab, and they're very similar problems without any common working. So that's, I think, the whole idea of the institutes, and I think it's been very highly successful.
And I could add a little bit to that. I think the thing that it really brought to the fore is the fact that having the molecular biologist right here dealing with the clinicians to share the information they have,
Yeah.
it changes our approach to the clinical side of things, so that we can then improve the outcomes and also, learn a little bit more about the genetics and about, how to go about that. So in terms of bringing everybody together rather than everybody, being in their own little silos, whether it's across the street, whether it's here, whatever.
Yeah.
I think it's also that important aspect of applying the bench research to the clinical stuff, and it's much easier when you're sitting next to each other to say, oh, by the way, or if you have a conference, oh, by the way.
So one question that wasn't on our list, but on my mind,
Yeah.
partially because of something I just read the other day, has to do with quality improvement work within the division. I saw an article that was in the medical staff bulletin about fabulous outcomes for this clinical program. And I'm not sure if you're involved in those QI initiatives, but can you?
Sure. Yeah, I'm involved peripherally. I think that quality improvement is really, Cincinnati Children's really is the mecca of quality improvement. People who come to interview here are like, oh wow, you guys are like the center of the world for quality improvement, and the Heart Institute's not an exception to that. So we have had what we call a SQV, or safety quality value approach, with directors in each of those areas, and then regular meetings where we each group will present. So for example, the electrophysiology group will present what we're doing in those areas, looking at patient safety, looking at quality improvement, and looking at improvement of value to patients. Again, I think that's been really very successful. Again, we've modeled these things off of what's been done hospital-wide, and then one of my colleagues in electrophysiology, Jeff Anderson, is very involved as the Chief Quality Officer in the Heart Institute, and also now has taken a position really in the hospital in that regard as well. So I think that the other thing is that in addition to the quality improvement, I think, is transparency. And I think all of cardiology and cardiothoracic surgery has recognized that transparency is necessary. So, it used to be that, well, we don't really want to put our data out there and have people know that there's a 3.7% mortality rate with this operation, because somebody will look at some other place and say, oh, they have a 2.8% mortality rate, and then they'll go there. But I think we recognize that we really do need to be transparent with the information, and If our rate is a little bit higher than somewhere else, well, so be it, but we need to work on that and improve it. And I think that in addition to being helpful, extramural, also, going to people outside the hospital, being aware of what's going on here. I think it's helpful for everybody here to know that, because sometimes I think people, you remember the bad things, and you sort of think things are probably worse than they really are, and then when you look at the real numbers, you go, oh, well, that's really pretty good. And if you're not sharing that information on a regular basis, then again, I think you do have a tendency to have a bias towards remembering things that aren't good, and thinking that things are worse than they really are.
Yeah, well, I mean, pediatric thoracic surgery is a high-risk specialty.
If I might add to that, with the transparency idea, is we now have this family group-oriented that meets with the cardiologists, and they discuss so that the families are actually involved now more directly. And that, I think, has also helped with this whole business of transparency, and they feel more comfortable. And if there are problems, let's say they feel that the kids haven't been treated well or whatever, they can explain their unhappiness, et cetera, and we can help improve whatever's going on. So I think that, which again is about a 10, 12 years that was established, I can't remember, in any event. So I think that's also added to this whole business of improving quality, improving the transparency, so that the families don't feel like they're left out in the whole discussion.
And we learn so much from them too, in terms of, we do something, we go, oh, that went very well. It went very well for us, but then when you look at it from the patient and parent standpoint, sometimes like, well, it didn't go so well. So it really is very transformative, I think.
So speaking of patient information, one of the things that we are curious about is the Heart Encyclopedia, and how that got started and how it's used.
Because I think that was the first, I think you were the first division in the medical center to have anything like that online. Was it?
You know what? I don't know when it was established.
Do you know what?
But I know it's out there, and of course it's very helpful. Instead of going to Google, which may have correct or incorrect information, they actually can go online and look at the Heart Encyclopedia and look at whatever lesion or type of problem that their child has, and get a much better, not only visual in terms of what it looks like anatomically, but what is being done, how it's going to be done, et cetera, et cetera. So, and I can't honestly tell you when that was developed.
I don't remember the when, but I think it was Rob Beekman.
I would say Rob Beekman was kind of the person who spearheaded that, and I think just to sort of carry that on to today, now we can print 3D models. So you can actually take a child with a very complex heart, you can actually print a 3D model. And the other thing that Ryan Moore in our division is doing is this artificial intelligence and this sort of virtual reality and augmented reality, where he basically, a lot of this has been with Dave Morales, where they put in ventricular assist devices, and you can imagine that ventricular assist devices, just like the things that I deal with, pacemakers and defibrillators, are not made for children. There isn't a market really to make them for children, and so they take adult type devices and try to squeeze them into children, and figuring out how they're going to fit, where they're going to fit. So Ryan can basically do 3D imaging, and then he can do 3D imaging of the device, and then he can work with David and say, well, how about if we turn it around this way and put it over that way, and it will fit inside the body in that fashion. And so they've been able to do tremendous things with that. And I think the other thing is using those same sorts of techniques with families, where you can actually take the family inside the heart and say, look.
Just like Fantastic Voyage.
Exactly. No, that's exactly right. But I mean, I think that, Dick and I work with these things all the time, and so our minds, we can just sort of look at something sketched on a piece of paper, and sort of in our mind we can figure out how that works. But I think if you don't do this all the time, you don't understand those three-dimensional relationships, you go, I don't really understand. What are you doing to my child's heart? And when you can actually take them inside the heart, you can take a heart model and say, here's a model of the heart, and this is what it is, and we're going to connect this with that. Then they, oh, now I understand. You know, you've taken it to a level where they, you know, the audio visual can really get them to the point where they really do understand what's going on, as opposed to saying, I don't get this at all. I just have to trust this person to do the right thing.
No, that's fascinating. That's how all the things develop. How about the training program? I don't know if you're involved in that, but how big is that? How many?
It's massive.
It's massive.
So yeah, when I was a fellow, I think we had probably about, so there were 2 in my class, and I think probably 3 the year before that, and 2 the year before that. So it was like, you know, 7 what we now call categorical fellows, meaning your 3 years of cardiology fellowship.
Okay.
So now we have 15 categorical fellows,
Wow.
5 per year, and then we have more than that now. I think we've got like 19 or 20 advanced fellows. So we have a fellow in electrophysiology. There are 2 or 3 imaging fellows who do echo and cardiac MRI and CT. There's a fellow in interventional catheterization. There's a fellow in preventive cardiology. There's a fellow in adult congenital cardiology. So again, there's a huge number of fellows that are, and that's, you know, when you said things that are supported by the hospital, that's something that is very strongly supported by the hospital. So it's hard to find money to pay for these positions. You know, we can get grants here and there, but the hospital's been very strong in support of training of these individuals, and that really is critical to the development of our field. You know, you know, cardiology. You know, people ask me, you know, when you started in electrophysiology, how did you do this? Because it's like, this is there's so many, and I'm like, well, first of all, there weren't as many things.
There weren't as many things.
The bar wasn't very high. You could just step over it. You didn't have to jump over it. And now, again, to get people trained up to the point where, you know, even to go out and practice with somebody else is challenging. I mean, it takes a lot of time, it takes a lot of effort, it takes, for these specialty areas, beyond the 3 years of training. I mean, even when I did it, I did, you know, 3 plus 2. And you need at least that now.
Well, especially as it's gotten more technical.
Without a doubt. And again, I think the hospital supporting that is, I think, incredibly helpful to the field. I think it's going to be very important to the hospital too, because I think it puts our stamp on the map where, you know, this is the reputation of Cincinnati Children's. We train very good cardiology fellows. We train, you know, very good advanced fellows that go out and become leaders in their fields.
Is this one of the top programs?
Yes.
I mean,
we actually have the largest number.
Of course, it is quality-wise, but size-wise,
size-wise, we have the most. We have the highest number of fellows in cardiology of any program in the world.
Wow, in the world.
In the world,
wow. Wow.
That's
fantastic.
amazing.
Yeah.
Fantastic.
Like I said, it's really because of these advanced fellowships, and it's because of the support that the institution puts on that.
Wow. And I assume also because of the range of patients here that
Yes.
people get to
There's no doubt that, again, people want to come here for training because of the support of the faculty here, because of the number of fellows that are here, because of the variety of patients that are here, because of the technology that we can offer, because of the ability to do research. So again, to work with, you know, top-notch bench researchers in many cases is a real draw for people, because if somebody wants to do some part of research to get a top-notch clinical training and top-notch bench research training at the same place at the same time, you can't beat it.
Right.
Yeah.
So is a large percentage of the patient population you serve, is it local, or are people coming nationally and internationally?
We have people coming nationally and internationally. So, you know, we do obviously serve the local area and the region, but
And
we
the
also
world, really.
we also have patients coming from, you know, for example, this morning we had our case management conference. So these are patients that are presented for consideration of surgery or other intervention, and there, I think we're probably 15 or 17 patients presented this morning, and of those, 5 of them were second opinions from other programs. And they're not second opinions from some small programs number. These are second opinions from somebody who was at Boston, or somebody who was in Philadelphia, or somebody who's in Texas, is being presented here for a second opinion.
Yeah, wow. And of your fellows, trainees, are there others who either have stayed here or gone elsewhere and done great things?
Leaders in the field.
Leaders in the field.
Dick has an entire cadre of
Yeah, well.
people that he trained who went out to be directors of echocardiography at their respective programs, and directors of cardiology. We were talking about Tom Kimball a minute ago, who now is director of cardiology at Children's Hospital in New Orleans. But again, it would take more time than we have to talk about all those people. I've trained a number of electrophysiology fellows who have gone on to be directors of electrophysiology at their programs as well.
Wonderful.
And what about mentors of yours? You've mentioned some, but we know Dr. Kaplan is number one on the list. Other people.
All of them. I mean, every staff person is really a mentor. Whether it's in cardiology, whether it's in electrophysiology, whether it's in echo, whether it's in surgery, they become mentors for the cardiologists and the cardiology
or whether it's in life. And I'm very serious about that. I mean, I think that, really, again, Sam Kaplan, Ted Chow, Winston Gama, I mean, I think they all, taught me how to be a doctor. They taught me how to be a person. Jennifer Logie. I mean, again, this has been a fantastic place to be because of all the people who I've been able to learn from, both who preceded me and those who came after me.
And also how to maintain a family, because we're very busy, but you need, if you have a family and you have children, you need to know how to balance, at least, maybe it won't be balanced, but at least you know how to deal with that. And I can remember when Dr. Kaplan, always, whenever we went to meetings, he said, your wives are coming with you, okay, so that they weren't left home when we went to meetings.
Interesting.
And so the same thing when I went to speak, back in the days when there wasn't much echocardiography and people were interested, I'd always managed to take my wife somewhere, or actually took the whole family to South Africa at a time. So I tried to, again, balance, family life with our business and our what we did. And I think that was another thing that Molly and Sam helped us learn, and subsequent other people, whether it's Winston Gom, whether it's Ted Chow, whatever. And so that's another aspect of becoming a human being, becoming aware of what's going on. And,
Dr. Doyne said we should remember to ask you about Molly.
Oh. Well, Dr. Kaplan was actually a fellow with one of the leading cardiologists in the world, Paul Wood, in London at the time. And he and Molly had worked together in Johannesburg. And so I guess when his brother said, why don't you come over and spend a year in pediatric cardiology? And that was when Louise Rao was here, Lyons was here, et cetera. So that's going back a few years.
Okay.
In any event, and Sam became very interested in congenital heart disease, and that's how he got involved with, Helmsworth and also Lee Clark, and helped develop the oxygenated heart-lung machine, because people sometimes misunderstand. We didn't develop the heart-lung machine. What we developed was the oxygenation, so that you could then stop the heart and still oxygenate the muscle, et cetera, et cetera. Anyhow, so he asked Molly, would you think you might be interested in coming to to Cincinnati? She said, oh yeah, I'd love to see the Indians and cowboys. That was one of the classic things. But she was like that. I mean, and in any event, so I always remember that. Yeah, I'd love to see the
Indians
and cowboys.
Oh dear. Well, we're doing well. Is there anything that we haven't covered that's on your mind that we particularly
I think we pretty much.
I mean, I would think we, we could go on, we go on for
we could
days.
go on for
Right,
a
yeah, I
long
mean, a long
time.
time
It's
talking about specifics, but.
It's fascinating.
And
how
I
the
can
field
remember
is.
when Morales first had that 3D, remember when he actually used it to operate on somebody. I can remember when that came out that he was able to use it and in the operating room.
Is there a role for the stethoscope anymore?
Well, I think there is.
I always carried one,
It's,
I always used one, but really.
My wife's cardiologist, and my doctor still uses one, and I even use it for my wife. So yeah, I think it's first beginning to let you know that there may be something underlying that needs to be further investigated. So yes, I don't think we're ready to hang it
We're
up.
not ready to hang up the stethoscope.
And if nothing else, I think it maintains a connection to the patient. I think if I didn't learn anything from what I heard, having that connection to the patient, having your hands on the patient. I actually had a patient's mother a few weeks ago when I examined her son, and it's a patient I followed for a long time, and she said, says, of all the doctors that I go to, and I have some medical problems, and all the doctors that he goes to, because he has a heart problem and other problems, says, you're the only doctor that ever examines either of us.
Yeah.
And
Believe it, yeah.
again, I think that people feel that connection. I think, again, you do learn a lot. It's a new patient, even with an old patient developing a new problem. I think you learn a lot by listening. But even if you didn't, I would still do it because, I mean, even if you had some magic machine that gave you all the information, I still would say, I want to
It's a
touch that
connection.
person. I
It's a
think that's a connection that you
Yeah,
have to those
absolutely.
patients that
Yeah.
you don't have when you're sitting at a keyboard saying, so
Yeah.
tell me about this.
Yeah, right.
And they don't want to just think, oh, I'm just going to get tests.
Yeah,
You know?
yeah.
And
You want to
as
see the
Tom-
doctor.
As Tim says,
I
it's a
think
personal.
that's what makes people think, oh, I don't need to go to the doctor, I can sit and Google this on my
Yeah,
own, I can
right.
figure out as much as they can, because
Yeah.
that's all they're doing is typing something
Yeah.
into a computer anyway.
Yeah,
It is about a
Very important.
relationship.
absolutely,
Yeah.
absolutely.
Very good. Well, thank you so much.
Thank you
We
both
really
for coming.
appreciate
This
it.
has been
Well,
been
thanks for
great.
having us.
Yeah, thank you
Yes,
very much, we
thank
enjoyed
you.
it.